Okay, we're getting ready to go live. And you're live.
Thank you, Sydney. Thank you, everyone, for joining us today. Thanks to our panelists. This is the first Facebook Live for this year, 2020, and we're excited to have brought together this really diverse panel of PhD students from the Johns Hopkins School of Nursing to talk about their research. Today, we're really talking about the future of research, and we're excited to hear from this really wonderful group of PhD students. They will talk about the problems that their research is addressing and the solutions they're proposing to some of these issues, and also generally what it's like to be a PhD student at Johns Hopkins. So we'll begin shortly. We'll meet our panelists first. They would introduce themselves, and then we'll really delve into this a little bit, a little deeper. So panelists, we'll start with introductions. Sarah Sloan, would you mind going first?
Be delighted to. I'm Sarah Sloan. My interest is in acute cardiovascular care, and I'm a DNP to PhD student. Really, my interest in the PhD program and furthering my education evolved while I was in the DNP program, because while I found that implementing research findings is one thing, sometimes there's other research questions that arise. And so I'm using my PhD as a springboard into further developing interventions to improve cardiovascular care.
Thank you very much, Sarah, for that wonderful introduction. John, would you like to go next?
Sure. Good afternoon, everyone from Baltimore. My name is John Swin, and my research focuses on hearing loss and loneliness among aging populations. My background is in clinical audiology. So I'm an audiologist studying here at the School of Nursing. And so I bring a little bit of that clinical insights from hearing loss and hearing care and training at nursing with the Department of Epidemiology at the School of Public Health as well. So doing a little bit of transdisciplinary investigations of what is the relationship, what is the trends that we are seeing from a population level, and it's all to inform screening practices and intervention development, because that's where, as a clinician, might generally want to leverage my research for is affecting transformative change in healthcare.
Thank you very much, John. Alana?
Good afternoon, everyone. My name is Alana Bergman. It's so nice to be here with you. So my background prior to entering the PhD program, my training is as an infectious disease nurse practitioner. I spent a number of years working in Ryan White funded HIV clinics. And it was through that work that I really saw how stigma impacted people's lives negatively, both in terms of their mental and emotional health and their ability to engage in HIV treatment services. So from that clinical practice, I started to develop a research question trying to explore how can we mitigate stigma in HIV. And the more I started to look into stigma, the more multifaceted I realized it was, and how we really can't pull apart HIV stigma from racial stigma when we're thinking about sexual orientation, gender identity, all of these really complicated cultural constructs that feed into our identity and how they all impact our ability to engage in care and cope with our mental health. So that's really where my dissertation is focused, is looking at sort of like the theoretical and the quantitative measurement models that we use to bridge the gap between theory and measurement.
Thank you very much, Alana. I'll introduce myself briefly and then we'll really get started. My name is Bumi Ogungbe. I am also a PhD student and I study cardiovascular disease. My current research is focused on myocardial injury and inflammation in persons who have had COVID-19, including cardiac-related post-acute sequela of COVID-19. So really interesting stuff, really timely. I'd like us to note that this will be a little bit informal. It's a little bit cold in most cities today. So grab a hot cup of tea or cocoa and let's have a fun discussion. So thanks again for introducing yourselves. And you started talking about some of the research that you currently work on, and I'd like us to delve a little bit into that some more. Would you mind describing the exact research problem that you're working on, particularly your dissertation and maybe other work that you currently do? And we really want to know where the gaps are as far as this topic is concerned, and how you came about that topic as a research problem that you really want to work on. So I would start with John. Would you mind kicking us off?
Sure. So I have a passion for working with older populations. On a personal level, I was raised by my grandmother. And so I just, from a very early age, was very, I guess, enamored by being around older people. And so hearing loss also on a personal level runs in my family. And so I was introduced to it very early on. And I observed that it was a condition that was normalized as a part of aging, as in, oh, it's normal, you're getting older, this is supposed to happen. And that in effect contributed to health behaviors therein not acting upon it, not doing anything about it. And I noticed a lot of impacts that it had on family dynamics and particularly communications. And so when it comes to studying hearing loss and loneliness, the gap that I wanted to target was, firstly, not everybody who has hearing loss experiences isolation and loneliness, but for those that do, there's something that's unmeasured that we don't know why they may be at higher risk over others. And so my interest is really, okay, from a practice standpoint, how do we identify what should we be looking for? And so starting at the population level through my epidemiologic analyses, that part of my dissertation, we want to see from a higher level, what are the trends? What are the things that we can measure that we see that are having an impact? And then I should mention my dissertation is also mixed methods. So I would follow that up with some qualitative analyses to really understand. So these are the trends, these are the patterns, but let's explain why this is happening. And that's crucial because if we want to intervene upon these issues, we need to know what are the mechanisms, what are the drivers, and furthermore, what are people's experiences that we should consider in any sort of intervention designs. And so, like I mentioned earlier, as a clinician, I want to leverage research to impact transformative change. And in the healthcare system, that means developing screening practices as well as intervention practices. And yeah, I'm sorry, Bumi, was there another follow-up question to that?
I think you've done a great job so far. If we would move on to Alana, and then we'll probably come back. I do want to encourage everyone who is currently signed on and who has joined us to please ask questions. John just gave a really comprehensive description of his current work. If you have specific questions about that, please put them in the comment section and we'll ensure to get to them. John, we'll give you a break. We'll come back. Alana, would you mind talking about your work?
Yeah, absolutely. So like I said earlier, my dissertation and my research work here at Hopkins is really informed by my clinical practice. And when I first came into this program, I sort of took for granted that there were going to be really good measures of stigma that I was going to want to use in my dissertation. And the more that I learned about sort of how complicated stigma is, and as I started to explore intersectional stigma, meaning like all of the different components of our identities that contribute to marginalization and social erasure, I realized that there really wasn't a great way to measure that. There are no intersectional stigma instruments that are out there. So I was like, Okay, so I have to back up my dissertation a little bit. So my dissertation looks at a couple different things. Number one, we don't really know if or how stigma changes throughout care. So we don't know if, stigma is potentially at its highest point when people are newly diagnosed with HIV, or, when they first come out, or different things like that, or if the longer that you're living with an identity or a condition, if it gets worse, if it lessens. So the first thing that I want to do in my dissertation is measure stigma throughout the tuberculosis and HIV care continuum. And then the second thing that I'm going to be looking at, similar to John, I'm also using mixed methods. And in addition to looking longitudinally at stigma, I'm also going to be doing serial qualitative interviews to try and see if the measurement models that we have accurately reflect the lived experience. So both having people complete a questionnaire at different points throughout the treatment cascade, and then also talking to them about their experiences. And, if you scored low on this particular test, like, is that consistent with what you're feeling and experiencing and hearing from your communities? So I'll really just sort of be looking at that different data across the care continuum.
Thank you, Alana. Again, a very comprehensive description. We're going to come back again to some of the things you just mentioned. Sarah?
Thank you, Bhumi. So my interests really focus on disparities in cardiovascular care. And sadly, from a landmark study in 1999, it's been observed that clinicians actually react to patients differently based on their race and gender. And from my practice, I noticed that there were patients, particularly who lived in rural areas, where they didn't have access to advanced diagnostic chest pain to diagnose their chest pain and rule in or rule out a myocardial infarction or a heart attack, that there were definitely differences in care. And so there's so many layers to that. In order to really develop a successful intervention, you have to drill down and find the why. And so really, as part of my dissertation, I'm going to be looking at referral rates for diagnostic testing, and then stratify how many diagnostic tests, the selection of the diagnostic tests based on race, sex, and geographic location of these patients, and whether they present to a hospital that has advanced diagnostic capabilities, and could see if it's a hospital referring pattern issue. And then finally, examine with providers how the patient presentation and how the patient talks about their history of present illness really impacts the provider's initial diagnosis and selection of diagnostic tests.
Thank you very much, Sarah. Thank you, everyone on the panel for sharing. And we're going to continue on the same topic. We do have some questions. I would also share a little bit about my current research, which is focused on persons with COVID-19. And because this virus is actually, the pandemic is ongoing, it's still evolving in many ways. And in the beginning, what I really wanted to do was to see what the cardiovascular effect of this virus is, really how is this virus affecting the heart, particularly in people who may already be at risk for developing some form of cardiovascular disease. And that's why I'm looking at signs for myocardial injury and ongoing inflammation. And now that we have a lot of people reporting lingering symptoms after they've had COVID, part of my work is trying to quantify that and see just what are people reporting, what kind of cardiac related lingering symptoms are they reporting, and what does this mean in terms of therapy and management. We don't have a lot right now because, again, this is rapidly evolving, but I'm hoping that my work will contribute to the quest to finding A, the mechanisms underlying these lingering symptoms, and B, contribute also to therapy and management of some sort that we'll be able to pull together to address long COVID, as a lot of people like to call it. Okay, so that's for me. We'll keep going. I do want to, so a lot of us, John, Alana, Sarah, we did mention the methods, our research methods, and some of the data we're collecting, or how we plan to collect this data. And one question I do want to ask is, moving away a little bit from the theoretical part and really looking at what this means in terms of actual impact. If you were going to explain this to your grandma or your grandpa, and you really want them to get why this is important to you and why you're spending so much time and efforts to do this, how would you explain this? What would you say is the main impact, and how can your work be translated really? Eventually, we know that may not be a short-term thing, but how do you hope this would be translated either into practice, policy? I'm sure you understand what I mean. Okay, so we'll go. I would not spend too much time trying to explain what I mean. You completely get it. Sarah, would you like to go first again? Because I know you left off, you started to touch on that a little bit.
Yeah, absolutely. So, if I were to explain it to somebody who wasn't a clinician, I think if you could really distill it down, it's about improving diagnosis. And so you don't have patients undergoing layers of tests that they may not need, but conversely, also not undergoing the tests that they need. And really, by identifying, what's causing clinicians to choose different tests, or how much of the influence of patient factors influence testing, that's how you start to develop interventions. And in the future, if it turns out to be a hospital capability issue, an access issue, it could be something like leveraging policy down the road. Maybe we don't want a interventional cath lab in every hospital, but it could be something like leveraging new technology that's gaining traction, like CT angiography, to identify lesions in coronary arteries at some of these locations to start to better streamline the process.
Thank you very much, Sarah. Alana?
Yeah, I would say, so again, part of the reason that I did this is because of my practice. I spent so much time as a nurse practitioner sitting with patients and holding their hands as they cried to me about how much being diagnosed with HIV had impacted their lives negatively, how they felt unlovable, and that they were afraid that they were never going to be able to have meaningful relationships. And they were still very entrenched in this narrative of HIV as a death sentence, with this sense of fatalism associated with their diagnosis. And I guess my motivation is that it doesn't matter to me at all how you became ill, but everyone deserves a quality of life. Everyone deserves to be able to engage in respectful and treatment that makes them feel safe and secure. And that's what I want to be able to provide to patients. So I think by starting to pinpoint where, like, what are the antecedents of stigma, like where can we start to reduce some of the stigma that patients are internalizing, perceiving, and experiencing, and knowing at what point during their treatment trajectory things might be the hardest for them, we can really tailor our interventions to make sure that they have a better quality of life in terms of their emotional and mental health, to make sure that they adhere to treatment so that their life expectancy is long. And in terms of public health as well, we know that when people are on their HIV treatment and they're undetectable, they can't transmit the infection to other people through sex or any other types of behaviors. So it's important on an individual and a public health level.
Thank you, Alana. And just to summarize for our audience, we have now heard that Sarah's work is really focused on improving current diagnostic tools, and Alana is really looking at hopefully contributing to interventions in the future that would take into account the emotional well-being of patients and really help us at some point, I kind of don't want to use the word eradicate, but move the needle as far as stigma and HIV is concerned. John, do you mind sharing? And I know you started to talk about this too, so I do want to give you the opportunity to expand on why this is very important to you, and if you could distill this down a little bit, how would this affect or impact individual lives?
Sure. So building off of and in a different direction, what Alana was mentioning about stigma and what you said just now, Bumi, about moving the needle. The truth of the matter is hearing loss largely is not regarded as a health condition of concern because it's benign in some sense, is kind of how people look at it. However, there is a growing body of literature, of evidence that's showing that left untreated in the long term, we see a lot of adverse outcomes independently associated with hearing loss. And from a bigger picture perspective, one of the explanations for this is for the first time just recently, I think it was in 2020, 2021, according to WHO estimates, the human species, for the first time in recorded history, we had more older people over ages 65 and older than there were people who were ages 5 and younger. And so we are sort of experiencing what's also referred to as the third era of public health, which is we're now seeing the impacts of our health as we age, because we didn't really have on a population level so many older people. So we didn't know a lot of how our body aged, and furthermore, what conditions we need to contend with. And so the impact that I see that I can have is really part of this broader momentum along with a lot of researchers that I have the fortunes of working with here at Hopkins, to shift the narrative about hearing loss, sensory impairment in older age as not something to be ignored, because it translates to what I mentioned before. In my family, we observed hearing loss coming on, but we didn't think it was anything that we needed to do anything about it, so we left it alone. So the impact is to shift that narrative of how do we promote healthy aging through accounting for sensory impairments, whether that's through interpersonal engagements, but also on a systems level for providers. What should providers be doing? How should they accommodate an older patient that comes in and can't hear them and is not amplified with any sort of technology? What can you as a provider do to accommodate this? These aren't practices that are widely implemented yet because there haven't been a lot of research dedicated to it. For decades, aging studies wasn't a very sexy topic to study because firstly, there weren't many people as it is already. And I would claim that there's also just different priorities elsewhere. So the impact, again, is to shift the narrative to really promote healthy aging and accommodate for these very common, highly prevalent conditions, such as sensory impairments.
Thank you very much, John. Thanks, everyone. It's interesting to see the pattern. John, you talked about how this is something that you personally experienced in terms of your grandmother, and how this is where a lot of the motivation and the passion for this work originally came from. And Sarah and Alana, you did talk about your practice and the population you've worked with over the years, and how all of this has sort of influenced your choice of this research, and also fuels your passion for the current research. And I'm making the statement for the benefit of prospective PhD students or even current PhD students who have joined us, and how sometimes formulating that research question or the area of focus could come from a lot of places. It could come from personal experiences. It could come from practice or work or something you've noticed. And so it's important, and I think it's valid to to bring this into your work, to bring in your past experiences, your personal experiences, because all of this serve a very important purpose in moving research forward generally, and in moving the work that individuals have chosen to do forward. Thank you. So thank you very much for that. In my case, there are several pieces to this, but it's primarily because I think very early on in during the pandemic, and I keep making reference to the pandemic because obviously I study COVID-19. I want to be very conscious because I know we're all completely inundated with COVID-19 information. But it became really clear to me and to a lot of other people that I work with that there's going to be lasting consequences from this. And this is very typical of other viruses that we've seen in the past. And coming from, I am originally from a middle-income country, and we still have a lot of a very high incidence of infectious disease. So I'm quite familiar with chronic conditions or consequences as a result of a viral infection. And that's really why I thought this would be something to really work on, and also why I'm interested in working on this. Okay, so we're gonna move on a little bit, and then I do want to just one other question about your research, and then we'll talk about all the things. Are there lessons learned so far? And I know each of us are at different stages of research, and I was wondering if you've got those germs, those pearls of wisdom, that you'd like to share with people who have joined us today. And yeah, John, please. I was just going to say.
I'll start. For those who've had experience flying in an airplane, we have to be reminded every time that before you put the oxygen mask on the child, you put it on yourself first. And so translating that to being a PhD student, we have to take care of ourselves. We have to make sure we prioritize our health and our wellness, because we're all doing very important work. I mean, you heard from my fellow panelists here that these are very impactful work. But if we can't do it because we're not taking care of ourselves, it's not going to succeed. And so one of the first lessons that I want to emphasize is you have to take care of yourself, because you are contributing very critical and crucial information to the scientific literature, and we need you.
That is very important, John. Really cannot overemphasize that point. Thank you very much. Sarah?
To build off of what John was saying, really, you have to learn the power of no, because as a student, as you start to disseminate your research and people become aware of your work, there will be so many opportunities that are presented to you, and they may all be fantastic opportunities. Unfortunately, there are only so many hours in a day, particularly if you're trying to maintain some semblance of work-life balance, because I think I can speak for all of us on our panel. We are more than just PhD students. We have families and other hobbies that we like to engage in. So really, prioritizing things that will really help build your career and build your research above all else.
Thank you very much, Sarah. I do want to encourage everyone to start sending those questions in or comments that you have. And Alana.
Yeah, I would definitely echo what John and Sarah have said. To go along with that, I would say, so I'm sure that everybody on this panel has at one time or another experienced imposter syndrome and questioned whether or not they actually belong in this group of absolutely brilliant people. And one thing that I've definitely learned is that there is no one model of a Hopkins PhD student or a PhD student anywhere. Like, we all have come to the table with different skills, different backgrounds. Some people have extensive clinical experience, some have none. Some people come in with lots of publications, some have none. Everyone is doing really impactful work. And it's so cool to see that and to see how the other people in your cohort and your program progress. That's one of the most fulfilling things to me. There will be somebody that I haven't spoken to in a couple of months, and when I check in with them and I hear what they're doing, like, I feel really energized by the work that they're doing, because everyone around you is doing something awesome, and it's nice to have those people to lean on and to constantly feel inspired by.
Thank you. Thank you for that, Alana. I do want to emphasize your point about leaning on colleagues and peers, because you do hear a lot about a PhD being an independent journey, and a lot of people describe it as very lonely and isolating. In this program, this is something I've personally experienced, and a lot of, I think almost everyone on this panel will probably also give a nod to that, that we've had to lean on each other, we've had to lean on friends and colleagues, and it's important to note that and to realize that it may seem lonely, but you're not really alone. You can always lean on colleagues and call on people to help. I would like us to move along a little bit. We're going to talk more about other things, and we may come back to research, because I know that's probably what we all like, talking about our research, but we'll move along. I would say for me, I'd like to mention one thing that I failed to mention earlier was how I had to pivot from our original research question. As you'd imagine, I didn't come in wanting to do COVID-19 because we didn't have COVID-19 at the time, but I'd always done cardiovascular disease research, and I was going to really work on an intervention to improve hypertension medication adherence. But then the pandemic happened, and I really had to pivot. And just while I was trying to do a lot of introspection and see what would be most feasible at the time, I then realized that lingering symptoms from COVID-19, particularly cardiac-related ones, is something that we may continue to talk about for a while, and we really need to start working on in this area as early as we can. So that's my story. I'll pass the mic back to my colleagues on this panel, and this time we'll talk about the program in itself. So a PhD at Hopkins, and I know we're taking several steps back. For some of us, we're talking like several years, some years back before we even had the research question or something concrete as far as the research is concerned. Why Hopkins? Why did you decide why did you set your eyes on Hopkins for a PhD? And then we can maybe extend that into what opportunities or what the peculiarities are for pursuing a PhD at Hopkins. And for this, because I sort of see the wheels turning, John, would you like to begin?
Sure. Why Hopkins? So I do have a little bit of a unique background. I was doing my research fellowship actually at Hopkins before I started the PhD program. I was doing it through the Center on Aging and Health at the School of Medicine. And I was working on a pilot project at the time that was addressing hearing health disparities among local older Baltimoreans. And we have faculty from the School of Nursing who are on our scientific advisory board. And for me, I was already considering a research career and a research doctorate. And I was struck by the way that the nursing faculty in particular would advise me, respond to my questions, and pose questions of me about the work that I was doing and engaging with the community. And so it was those types of engagements with the faculty directly that inspired me to ask, would you guys accept a candidate who doesn't have a nursing background? And sure enough, the answer is yes, they do. And so, but why I stay at Hopkins is frankly the resources that we have, which it's not endless, but for me and what I want to do, that is public health related high impact research, the faculty are here, and the faculty, their careers, that's what they're orienting themselves towards as well. And so I wanted to learn in that shadow. I wanted to acquire mentorship through people who don't see research for research's sake, but research to actually impact health on a larger level through translating evidence into policy reforms or to even impact healthcare infrastructure or even directly down to practice. And there is so much expertise here at Hopkins. I have, just me as an example, I have 2 advisors, one in nursing as my primary and another one in epidemiology. And it is always exciting to go to meetings with each of them, but then especially when we all come together. I mentioned earlier, I would consider my research transdisciplinary, and that's exciting. It's working across disciplines to create something different and something that hasn't really been addressed before. And for me, merging audiology, gerontology, nursing, and public health is utterly exciting because I feel like I'm creating something new, or at least I'm one of the agents that's helping to create something new. And that's something that, frankly, here at Hopkins, I had the resources that enabled me and supported me to do so.
Wow, John, thank you very much for sharing that. I'm sure some people in our audience may be able to relate to that or could be thinking about that. And you sharing your experience, I'd imagine would be very helpful for them to realize that it's possible. It is possible to pivot in the way that you've done, or to do exactly what you want to do, or to work with people who you want to work with. Sarah, would you mind telling us a little bit more?
Sure. I previously had experience with Johns Hopkins School of Nursing because I earned my DNP in 2019 from the school. And so I already knew that there was very strong mentorship and resources at Hopkins. So when I started considering a PhD, and I was encouraged by one of the faculty at the School of Nursing, Dr. Douse, to apply, I really didn't consider any place else. I only applied here. And knowing that there was a Center for Cardiovascular and Chronic Care and well-established multidisciplinary research, it was the perfect fit. And to revisit what John said, it was so important, John, what you just said about, not doing research for research's sake, because there's a real risk in academia, largely because of the way it's structured, for promotion and tenure, to just have high output research that may or may not be impactful. And at least here, there's a real drive to make it relevant. I mean, to the point of having public advisory boards for research studies. And that's really highlighted to me why I'm at Hopkins, because it's about generating research that impacts the public for positive change.
Completely agree, Sarah. And John, it's important for us to think about the if then so what of our research, and not just do all of this really great work for the sake of doing them. Alana, would you like to contribute to this topic?
Sure. Yeah, my experience in applying for the program and coming to Hopkins was a little bit different. I did my bachelor's degree and my master's at schools that didn't really have strong nursing research programs. They were much more geared towards clinical practice. And I didn't really appreciate the contributions that nurses were making to research. So I never really saw that as a path forward for myself. And that sort of changed when I started engaging more and more in my professional organizations. And I, at one point, went to the National Conference for the Association of Nurses in AIDS Care. And I saw Dr. Jason Farley present at that conference. And fast forward today, he is my faculty advisor. But I was absolutely blown away by the work that he was doing. So that was the first time that it clicked for me that like this was a viable career path. So I started stalking him. And then I got even more interested in research. So when I applied, I knew that Hopkins was my top choice. I did apply to some other schools, but I was also sort of funneled back to Hopkins because I was also interested in tuberculosis. And there's much less of an emphasis on TB research in nursing. And Dr. Farley was one of the few nurse researchers looking at tuberculosis in the country. So there were sort of a few things that were pulling me here, but it was really, again, like the faculty and the expertise that's here that I couldn't find elsewhere that solidified my choice.
Such a perfect summary, Alana, faculty and expertise. And I would probably say the same for me. I wanted to work with Dr. Komodo Mensah, who does cardiometabolic research. And at the time, she was majorly studying African immigrant population. And that's really why I knew Hopkins would be a great place for me as far as a PhD training is concerned. I do want us to talk about, we started to talk about lessons learned, and I'd mentioned pivoting a little bit from our regional research, and I was wondering whether that's something we'd want to talk more, would want to talk about a little bit more. Has anyone had to make changes, significant changes to the research, and how have things like the pandemic affected or been contributory to some of the changes that you've had to make? And for this question, I'm not going to call on any of us. I'll just let anyone who think that they may have, they do want to contribute to this, just take the mic. And
yeah, I'm happy to talk about it. Bumi, I think that you and I were sort of in like a funny position because I think we really straddled COVID a lot. Bumi and I are both third-year PhD students, and we started all of our curriculum in person in 2019. And we're sort of just beginning to formulate our research questions and what our research aims might be. When the pandemic hit, so my advisor does most of his work in South Africa, and I had been with him in South Africa doing research at the end of 2019 until February of 2020. And then I had sort of committed to this international research, came back, and the lockdown started. So I did not read the tea leaves sort of as clearly as Bumi did, and Bumi adjusted accordingly, and I stayed the course. And I'm really happy that I did. I'm very happy with the research study that I've proposed, but there definitely are challenges that are associated with COVID. I was supposed to start my data collection in March of 2020, which is the worst time to start research globally. So fingers crossed, we're going to start March of this year, but definitely impacted by COVID.
Thanks a lot for sharing, Alana. Sarah, John, any thoughts, any particular experience about this?
So I'm in my fourth year. And so when the lockdown first happened in March 2020, I was already halfway into my second year. So by then my research question was established. The methods were still coming together, and in many respects, it hasn't really changed because of COVID restrictions yet, because I'm entering a phase of my research where I'm going to be doing primary data collection with older adults from higher risk backgrounds because of lack of healthcare access. So while it hasn't changed significantly, I will have to adapt funny enough, this coming semester itself, because I was planning on doing in-person qualitative interviews. And frankly, remote strategies is I'm not quite sure how that's going to work, because one, I'm working with older adult populations who have limited resources. So I can't necessarily assume everyone has a laptop for Zoom. And furthermore, I'm interviewing older adults with hearing loss. And so phone calls are also not ideal as well. However, so while my research hasn't really been impacted directly, what I will say is my research was delayed because of the data collection for the parent study that I was going to work on for my first aim. And so while that was delayed, I took advantage of this lull essentially and just got really involved in a lot of service projects throughout the university. And so, like we were all saying before, you have to learn how to say no. You have to learn how to say no because there's a lot of opportunities to stay busy. And that's how I took advantage of that lull in data collection where I couldn't do anything. Was I just got involved in program development, delivering seminars, and writing both scientific literature and non-scientific literature. So there's a lot of opportunities for that too here at Hopkins.
Thank you very much, John. Thank you for providing that perspective. Sarah, you came in right when the pandemic started. Would you like to share?
Absolutely. Yes, I interviewed in February 2020. And, at the interview, there was already reports coming out about the looming pandemic. And, sure enough, we went into lockdown March. And so I was projected to start in August and move to Baltimore. And so there was a whole decision tree I had to go through, is this the right time for the PhD? But I forged ahead and I'm now in my second year. I can say, for someone doing research looking at hospital systems, it definitely impacts the type of data and how I'm collecting the data, because we know hospital systems changed a lot. Many were overwhelmed due to the pandemic, and that caused changes and delays in care for cardiovascular patients that was totally unanticipated and not part of the norm. So really, as I'm working on narrowing down my methods, it's really a question of, do you focus on pre-COVID or do you look at the situation we have now? Because we know that the pandemic also impacted the nursing shortage and made it worse too. And that impacts patient care. So, while it didn't impact my research question, for the delivery and data collection aspect, absolutely, COVID's still impacting research.
Thank you, Sarah. One thing I do want to note in light of this conversation is how a lot of us on this panel are actually collecting primary data, and I do want to acknowledge that. And some of us, like Sarah, is really looking at secondary analysis. So for colleagues who have joined us, it is very possible to do primary data collection as part of your work. John, for instance, is trying to make that decision between what that would look like and if there will be needs to adapt. So flexibility and adaptability is part of this process, and it's important to really confront that when it's time to do so. Thank you all for sharing. This has been really, really enlightening. I do want us to talk a little bit about mentorship. And by that, I mean the mentorship that you've received so far, and the mentorship that you also give, because right now we are all nearing that point where we're beginning to have mentees and beginning to also establish some form of mentorship model ourselves. What does that look like for you, Alana?
Yeah, so I mean, both in terms of mentors and mentees, like again, Hopkins is the place to be. I have a variety of mentors that are at different stages in their career. And it's helpful for me to see what the opportunities are and what the perspectives are, just a couple years post-graduation, 10 years, 20 years down the road, because it helps me sort of like ground what my trajectory may look like. In terms of mentees, we're all required to do teaching residencies as PhD students. And that can be either in the pre-licensure program or in the DNP program. So there's a variety of sort of students that you can interact with. After I finished TAing, I continued, after I finished my requirements for TAing, I continued to TA for the same class several times. And now I'm faculty for that class and have, as a result, like developed mentees out of that sort of pipeline, people who are interested in going into clinical practice in infectious disease, but are also interested in looking at the PhD program. So there's a whole host of sort of mentorship relationships that you can nurture.
Thank you, Alana. John, would you?
So I'll start with this idea of having mentees. And so I mentioned that I'm training primarily at the School of Nursing, but also at the Department of Epidemiology, specifically the Cochlear Center for Hearing and Public Health. And in that center, I am the trainee who's been around the longest. And so they did formalize my role into essentially being a senior trainee. And so I have MPH students, SCM students, MHS students, master's level students that I'm viewed as the go-to for not just research per se, but also Hopkins. Like where do you go for this type of resource? Where do you go for this type of support? And honestly, it's actually a very good experience because it puts you in a position of really focusing on what somebody is asking and understanding where they're coming from because you're both students. And then responding in the context of being a student, because that's what you are as well, even though you may be a doctoral student speaking to a master's level student. In the School of Nursing, my experience has been through the Research Honors Program, which is a program that our master's levels nursing students are engaged in. These are students who, again, they're nursing students, but they have an interest in conducting research. And so I've been in a position where a faculty member has had a research honor student and I'm the PhD student working on the same paper. And I effectively would fall into this position because I have more flexibility than, say, a very busy faculty member to essentially explain a lot of these research fundamentals. What is qualitative analysis exactly? And it's been a really cool experience because in that context, it's a little more informal, but you really start to, at least I start to realize that you're acquiring a lot of insights for the day when you probably do become a faculty member, how you should engage students, what you should anticipate of the types of questions or gaps in their knowledge that they may have, that it's up to you to support them in realizing. So there's definitely a lot of opportunities for, as a doctoral student to be in a mentor position. As far as being a mentee with faculties who are mentors, I mean, I can just say the same thing that Alana said and what everybody else is probably going to say. They're amazing here. The faculty that I've happened to have the fortunes of coming into contact with generally are all doing this because they want to see you succeed. On a structural level, the faculties doesn't really receive anything in return for having you on as their mentee. And so them taking you on really is, in a way, out of their heart, because they want to see you succeed. They want to have a role in promoting you and your scholarship. And so I think that's something you can expect from many of the faculties here at Hopkins, in my experience as well.
Thank you. Thank you very much for sharing, John. Sarah?
And not to be repetitive, I'll take things in a slightly different direction. I think from the mentor aspect, you have both informal mentors that you have access to. And, John's 100% correct. For many of them, they don't get anything out of it, not even authorship if they're just talking to you about, small aspects of your research. And really what I've found very beneficial in terms of mentorship is getting somebody who's not cardiovascular or not clinical to look at my specific aims, to look at my research plan. Because when you get so into the weeds and focused on your research and you're looking at one lens, sometimes it takes somebody with a different lens to say, oh, well, have you considered this aspect? And maybe you need to highlight this because then this makes a whole lot more sense, or this adds a certain layer of richness. I know for me, the qualitative experts that we have at Hopkins have been wonderful to work with. And really, it's led me to add a qualitative piece by interviewing providers who manage care of the patient population that I'm looking at. In terms of having mentees, I think it's the same way. You have informal and formal mentees. And, sometimes those informal mentee relationships can be just as enriching, even if it's just something like both Bhumi and I are in a cardiovascular mentorship group, even if it's just sharing information about available funding. It can be a very rewarding experience because I firmly believe it's not a one-way street. If you're being mentored, you almost have a duty and onus to mentor others too.
Oh, thank you all for contributing to this. We really cannot stress the importance of good mentorship in the PhD journey enough. It's really critical. We do have a few minutes left, and I do want us to touch on one more topic before before we leave our audience. I was wondering, and this is also one of those questions where we don't necessarily have to go around, and if you have thoughts to share about this, just go ahead and grab the mic. About communication, research, communication, science communication. And I was wondering how this, what you're doing differently in your different research to ensure that the people who are most affected, the population you're studying, have access to your research eventually when we all finish this. I know in academia, publication is a big thing. It's what everybody, it's what we all do. But what are you doing differently? Any innovative ideas as far as science communication is concerned? Again, anyone can take this.
I can start off with this. So on a personal level, science communications is a topic that has really, not so much surprisingly, but caught my attention and something that I've really become super interested in, to the point that I'm considering maybe targeting a career when I'm in a position of science communications. But when I think about it, a lot of it probably does come from my experience doing community-based research here at Hopkins, and seeing that, in my opinion, part of why we see health disparities is the disconnect between academic institutions and the public. And academics, I'll say in a traditional academic curriculum, as scientists, we're not trained to how to communicate effectively, not just to other scientists across other disciplines, but to people who don't have science backgrounds. And so I have had the fortunes of finding people at Hopkins, again, very large institution. It is up to you to find some of these people sometimes, or through your networks, who have given me opportunities to really practice science communication skills and principles, and enabled me to have a role in producing even a pilot program targeting PhD students and postdocs at Hopkins. And I guess from again, bringing back to this question of how are we communicating the research, for me, from within academia, I am a transdisciplinary investigator. I need to learn how to communicate to different audiences from different disciplines. In a few weeks, I'll be going to a audiology conference where my presentation is on social epidemiology, which I guess within our field of audiology, public health and epidemiology is really still a very, very small group of people who actually are talking about it. So there are very few people who can speak about it across different, I guess, different disciplines. And so I cherish the opportunity to be able to do that because I see myself as facilitating engagements for innovations in that sense. And it's something that, frankly, my mentorship at Hopkins has really prepared me well to do that. And so bring it all together. Research communications comes from mentorship for me. It's something that was cultivated through my interest, but something that was nurtured by my mentors because they saw it as something that I not only enjoy, but that I am in a unique and privileged position to do.
Thank you for sharing that, John. And Sarah, you do want to say something, but in the time we have left,
yes, I'll try and keep it brief.
Okay, 30 seconds.
With research participants, I do think you have a duty to inform them of your findings, and particularly in a way that they can understand if they're non-clinical. And we know all too well to access some publications, it requires people to pay money. And so I think as researchers, it's important to circle back to your participants and share your findings, because then that way it doesn't feel as, I hate to use the term, saying it's exploitation, but at least the participants understand, what you gleaned from their involvement and have the ability to respond.
Thank you, Sarah. Oh, Alana,
I'll do a 10-second build on that because I agree, like subscription access is so limiting in terms of getting disseminating your knowledge. And I would also say that as someone who's studying international health, I'm not from South Africa. So the importance of including people and really promoting people who are local and can contextualize findings really help me to understand what's going on. And then not only that, but considering my audience, because if we are foreign global researchers who are only talking to other foreign global researchers in journals, what is the impact on the ground? And is our research even relevant if we're not considering our position and the audience that we're speaking to?
Those are all very important points. Thank you. Thank you for making those points and bringing in this perspective. We are at time, and I do want us all to have that opportunity to share with our audience just anything you'd like them to take away from this. And this could be anything from some of the things we've touched on, some of the things we've not talked about, research, not really research per se, just something you'd like people to go with. Alana, would you like to start?
Sure, I'll absolutely start. I will just sort of touch back on, this is a career path that's open to anyone. Like, you don't need to fit a certain mold to be here. And I would encourage you, if you're excited about health research and you want to, contribute to public or individual health, reach out, think about joining us, because there's a good chance that you belong here.
Sarah?
I agree wholeheartedly with Alana. And I think there's a misconception about what nursing research is, particularly for those who come from nursing backgrounds, because we had to take evidence-based, nursing research courses. If we had a master's as well, you had to take a similar course again. And so I just really want to encourage anybody who's considering the PhD. It is way more exciting than what's portrayed in evidence-based nursing research courses. And I highly encourage you to really consider a research career.
Thanks, Sarah. John?
And building off of what Alana said, that it can be anybody. If you were that kid, like I was, who annoyed the adults by always asking why questions, because you were just insatiably curious about everything in the world, you're probably a researcher, just saying.
That's awesome. Thank you, everyone. Thank you very much, Sarah, Alana, John. for joining us. From me, I do want to talk to anyone who is international. There's a place for you here, so definitely apply if you're considering a PhD at Hopkins. Secondly, February is the American Heart Month. Let's do everything we can to make sure our heart is healthy. Once again, thank you very much to our panelists. I do almost want to do an applause. You do deserve an applause. Thank you for sharing. Yes, thank you, John. Thanks for sharing this perspectives. Thanks for being open. And thank you to our audience. Thank you for joining us and for sharing your Monday afternoon with us. And I think we've come to the end of this Facebook Live. Thanks, everyone. Bye.